line is about the 23rd of March, and the last day was the 31st of August. So the blue line goes from the 1st of September to whatever day that was at the end of last week when we pulled this chart off, about Thursday or Friday. So you can see in the first wave how quickly the numbers accelerated in the QE, whereas through the autumn we've seen a very slow and steady decline which accelerated, and that's kind of a straight line. That's a fairly constant increase on a day-by-day basis, up to about 2-3 weeks ago, where it peaked, and it peaked at a higher level than it had in the first wave of the pandemic, and has then sunk back down. Whereas in the first wave of the pandemic, you had that extended plateau of about 3 weeks where they had around 110, 120 cases. We've had a similar period, I suppose, between there and there, and there and there, in that very high number. So that tells you how intense it's been in the QE over recent weeks. But fortunately, that has come down quite substantially and consistently for the last few weeks. And I think we're down to below 50 cases this morning in terms of the inpatients at the QE who've tested positive. They've also been struggling with staffing because every time a member of staff has to isolate, there's been high levels of absence for the QE, and I know that's been a real pressure that they've experienced. And I'm sure Steph has a similar feeling in terms of the provision of social care as well. The last slide in terms of the numbers I'm going to show you is it's a grim one, I'm afraid, and that's the deaths that have been from COVID over the course of the year. Now, each of these columns is a week, the number of deaths in a week. So the blue lines, blue parts of the columns show the deaths from causes other than COVID. The orange part of each week's bar shows the COVID-19 deaths. Now that's where COVID is mentioned as a contributory or leading cause of death on the death certificate. Okay, so where COVID was a factor in the death and has been recorded as such in the death certificate, then that is counted in the orange lines. And you can see, and the last thing to explain about that chart is the black wavering line there is the 5-year weekly average number of deaths. So you can see that you'd expect some variation around the average every single week, but from about week 14, from about week 13 or 14 through to about week 20, we had quite a considerable level of excess mortality, and that was almost wholly accounted for by COVID. I guess it's possible that some of this excess mortality that's in the blue line was COVID related but wasn't identified as such. That is possible, particularly in deaths outside hospital at the time, given the level of testing that was available. So, but you can also see that very, very high level of excess mortality that occurred then. A few weeks later, we had whatever the opposite of excess mortality is. So I think there is speculation. That's a relatively low dip by comparison with some other areas, I think. I think in some areas I've seen the charts for which have seen a more prolonged level of mortality, which is below the historical average. For Gateshead, that's quite short. And you wonder whether or not some of that reduced mortality is the flips. It just illustrates that some of the mortality here is just deaths that would have arisen anyway and has been brought forward a little bit by COVID. But frankly, that little level below the average is dwarfed by this excess in this period. We then kind of followed the historic average through until about here, which is about 8 to 10 weeks prior to the end of November. So this is this is early October when we're starting to see excess mortality come back. You will get anomalies in some weeks like this one here, but you can see consistently for the last 6 or 7 weeks for which we've got data, we've been seeing about 10 to 15, 20 even COVID-related deaths. Now, if you go back to that slide, you can see that the deaths kind of follows by a couple of weeks the peaks in the incidence of COVID. We've also looked at the mortality. Oh, by the way, we only go up to about the 20th of November here because it does take time for the mortality data to come through, because we're dependent on family members going through the process of registering the death. So there is time. Some people do have a little bit of time to do that. So we always delay the reporting of deaths by a couple of weeks. We've also shown you here the number of deaths that related to care homes, and you can see that we had the same excess in the peak of the pandemic. You can see more clearly that our potential underreporting of COVID-related deaths in this period, whereas in hospital you can very clearly see it's COVID-related. And we had some excess mortality back in about week 42, 43 in care homes. I suspect that was related to 1 or 2 outbreaks that we've had in care homes. Whereas in the hospital, you can see there's for the last 3 or 4 weeks, there has been a return to excess mortality there, which reflects the high levels of inpatients that we had just a few weeks ago as well. Okay, so the deaths tend to follow the admission by a couple of weeks. I'm going to pause there in case there are any questions on those data slides, Councillor, if that's okay. And then I'll go on to the other points that I was going to cover.
Any questions or comments so far to Gerald?
Chairman, can I ask a question?
Of course, Ian, yeah.
Thank you. This is for Gerald. In the figures you've just given out, has there been any clusters in any particular area, or are they spread across the piece?
I think we've seen high levels of COVID throughout Gateshead across the course of the 9 months. Now, if you pause the clock on any given day, you can see differences in patterns. But remember, one of the factors included that affect where we're seeing outbreaks include where we see people working, where people socialise, as well as where people live. So you can look. In the notes when I send this round, you'll see I'm including a map that's available on the national government websites, which allows you to look at the cases in medium super output area. Although that is fairly current data that's shown, but at different times we've seen the peaks and troughs in different parts of the borough. Where we've had outbreaks, for example, in care homes, that's distorted the numbers that appear in a particular area. So, for example, in early September, if we'd had an outbreak we had an outbreak in a care home in Blaydon in early September, but if we'd shared information showing there was very high levels of COVID in Blaydon, we might have provoked a lot of anxiety, which was unnecessary, because all of those cases, or virtually all of those cases, would have been contained within the single care home. So we try to be quite careful about sharing information about higher numbers in given parts of the borough, because at any given point in time that might be influenced by factors such as care home outbreaks or work-related outbreaks and so on, rather than it being an issue within the community itself. And most areas in Gateshead, as I say, have been at the top of the charts for the rates at different points in time. I think there is undoubtedly a correlation between deprivation and overcrowding and poor working conditions and stuff like that, and levels of COVID infection. So
thank you.
And that's true nationally as well as it is locally, as we've seen in things like the outbreaks in places like Leicester and Blackburn that were particularly highly reported in the summer.
Okay, Ian.
Thank you. Yes.
Any further questions, comments to Jared?
Shall I move on then?
Yeah.
Okay. Now, we are, as you know, currently in Tier 3 of the COVID restrictions nationally. I am not going to attempt to explain the differences between Tier 2 and Tier 3. That would take me about the next hour and provoke more questions than it would answer. If you really want to know that, please just go and look it up. Google local restriction tiers, what you need to know, and you'll find all the answers that you want on that. I think one of the main ones for me is about hospitality. However, but by all means, if you're curious, look it up. We know that the government has said that the tiers might change from next week. If they are to change from next week, I think they'll be using that based on the data that I've just run through with you here and now. So it would be no surprise to me if the North East local authorities are moved into Tier 2. They will not be moving Gateshead into Tier 2 and leaving South Tyneside in Tier 3. They'll be looking at it across the North East. Whether they'll look at it across the LA7, so Northumberland, Tyneware and County Durham, and Tees and Darlington as a whole patch or as two separate patches, I really don't know. It wouldn't be a surprise to me if they look at the LA7 and the Tees Valley completely separately and make a decision, two separate decisions on Tier 3 and Tier 2 for those two. Whether it should change or not, I have to say I would press for a more cautious approach. But then you'd expect a public health professional to be arguing for that based on risk, because I think if we take our foot off the pedal now, off the gas now, or take our foot off the brakes now, the risk is people relax and we'll see the rates start to rise again. I'd much rather we were able to keep the restrictions tighter for longer to allow us to begin things like the vaccination and so on programs. And of course, we've got Christmas as well, where we'll see some relaxation. And the last thing I think any of us would want is that false reassurance that everything's okay in Christmas. And then come January, we'll see a sharp rise in cases again, and we're back to where we were 3 or 4 weeks ago. That cyclical approach to it doesn't do us any good at all. However, we know that the government has had to promise its own backbenchers a review of the overall tier system in February. Otherwise, it wouldn't have got this far, I think, on that approach. A couple of other things that you'll have seen very much in the national press. One is this mass testing language that our Prime Minister has been talking about. This is based on the availability of this new form of testing called lateral flow testing, which is a rapid test. It's not one that needs to be processed through the lab. Essentially, it allows on-site testing of individuals without the need for lab equipment, and those results are generally available in less than half an hour. So it can be used to test asymptomatic people. It can help identify those who unknowingly have the virus. So it enables you to identify them and get them and their contacts to self-isolate, which can help reduce transmission. The issue with all these tests is the levels of false positives and false negatives that you get, because what you want is a test that you can rely on. Now, the level of false positives is relatively high in this form of testing. So, you might get a positive result, but not actually be carrying the virus or be infectious from the virus. So where lateral flow testing is being introduced, you need to back it up with a lab test as well for those who tested positive. The levels of false negatives are much lower, and it depends on. And so some reports have said, suggest it's less than 1% of false negatives, but bear in mind that you've got a lot more people will test negative, so you might have, so you could still see quite a lot of people in absolute numbers. If we tested the whole of the population of Gateshead tomorrow, you could still see maybe 1,000 people who are false negatives, and that's a lot of false negatives. You could. So it's it does have advantages in terms of its rapidity and its cheapness and its access, but it has disadvantages as well in terms of that false level of reassurance. So the government is talking about targeting that, rolling that out to care homes to enable visitors to get tested. And we are talking to our local care homes about their plans for that. I think we will see a degree of reluctance on the part of many care homes to implement it because of the investment they would need to make in terms of staffing and time and space to enable that testing to take place. They're talking about using it for university students to allow them to get home for Christmas knowing that they're not positive, and there are other sites as well. In terms of, and that's being rolled out, those kind of levels of care homes and universities are being rolled out directly by government. The government is looking to local authorities to roll out lateral flow testing more widely. Now, in the northeast, we are only looking at doing that in a very targeted way because we do not believe that mass testing tells us anything. It provides a false reassurance, and we don't think it'll help with control. Government has talked up the benefits of the pilot that there's been in Liverpool, and I think that's not justified. If you compare the trajectory of cases in Liverpool with other parts of the Mersey region, which had no such access to mass testing, the trajectory is exactly the same. So you can't argue that mass testing is the thing that's brought it down. And the other thing that mass testing does is it reaches the worried well and the middle classes far more effectively than it does reach deprived communities. So we're very clear that we need to adopt a targeted approach to help us do business better. So, for example, some of Steph's staff who aren't covered by some of the routine testing is where we would target the lateral flow testing for Gateshead. And planning is underway to kick that off as soon as we possibly can. Vaccination programme, and this, to my mind, really is the light at the end of the tunnel. If we can get mass take-up of the vaccination programme in Gateshead and across England, this really does offer the hope that we can finally see light at the end of the tunnel here. So there's a process that vaccines have to be put through to be approved as safe before they can come into use. And that's through a body called the Medicines and Healthcare Products Regulatory Agency. If you're interested in such things, you can Google them and see how they work. So far, unless things have changed this morning, and I've not checked that on the news, the only vaccine that's been approved, or BioNTech vaccine. The Pfizer vaccine is this one that has to be stored at minus 70 degrees, and can be moved a couple of times. So it's only suitable for hospital use and mass vaccination site use. The AstraZeneca one is more robust and can be moved around more, so is far more suitable for the vaccination programs that will operate out in the community. However, both of these require 2 doses, and it's hard enough to get people to come for a single dose a lot of the time of any vaccination. So getting people through the door twice is going to be a real challenge. And you think about that in terms of the population of Gateshead, that's 400,000 vaccinations that we'll need to deliver, or the NHS will need to deliver, and that will take a long time. So I think you're talking about best part of 6 months to get through all of that delivery to reach all the population. So that's a programme of an unprecedented scale, and a planning group is already in place, led through the CCG, looking at how we'll do that, how primary care will deliver that to the population of Gateshead on a mass scale. That will be done. There will be an order of priority, which will be related to risk. And so the overriding, I think, categorisation will be done by age, because that's nice and clear and simple. And as we all know, the risk of COVID does increase with age, and underlying health conditions are also more prevalent in the older population. So it'll be, for a lot of us, it'll be many months yet before we see, or several months yet before we start to get invited to be vaccinated. Okay, but the programme will begin. this month with hospital vaccination. And we can't give a timescale really for the community vaccination programme until we've got the AstraZeneca vaccine approved nationally, which could be any day now. So I'm going to stop there and happy to take any further questions on testing and the vaccination programme and the tiers. We'll try to answer any questions on that if there are any.
The figure you raised there, is that divided by, sorry, is that the single, or is it...
Councillor, you're muted, I can't hear you.
I'm definitely not muted.
No, Councillor Green's not muted.
Definitely not. So, Gerald, is that the 2 vaccines people have to have, the figures you're giving, or is that one?
I'm really concerned about people being...
I think there must be an issue, Gerald.
I'm sure it's me, but I can't hear anything at the moment.
Can you hear me, Gerald? So I'll try and answer the question. I think, Councillor Green, that what Gerald was suggesting, the 440,000 would be twice the population of Gateshead, right. So that would be the 2 vaccinations per person.
Right, the other one, my own stuff, I understand, I may be wrong, but I believe Harry Shugler, who's a good friend of Gateshead, was the first one to have the injection. I may be wrong on that, but I believe that happened.
Right,
or to be offered it, rather.
And right, I don't know if...
Go on, sorry, Steph.
I was going to say, I don't know if Gerald can hear again, or... No?
No, he's certainly here. Right, Maria Hall.
I can hear you now.
You can hear us now, great. Good, because I can't answer your questions.
Thanks, Chair.
You'll have to repeat that question. I don't know what was going on.
We've answered the first one. It's on to Councillor Hall now.
Thank you.
Thanks, Chair. It was just with regards to some of the information that's going around social media with regards to people who are going to have the vaccine will be given a card, and because this programme is going to take so long to roll out, is there any guidance yet or any information around people who haven't had the vaccination being restricted either in their movements locally, nationally, or if they wanted to go abroad? Because I know that it's starting to raise concern amongst residents that they may not be able to get to move around